mix up on some of the wording. So here we go. Let's try these one more time. Sympathetic stimulation. What will blood vessels? Which ones will do this? Come on, where is my function here? There we go. Gee whiz, still glitches. There we go.
Where's your cool one you were gonna bring?
I know, I keep forgetting it. Over and over again. I do, please do that. Oh my God. Every day I get here, I'm like, another day. As an elastic artery, so we're looking for a big artery. The common iliac and the aorta, yep. Systemic circulation with high resistance. The arterioles right there. Because these arterioles were known as the resistance vessels. That's where that comes from. Albumin, since it's a big old protein, we need some big spaces to get this through. That would be the sinusoids of those three types, yeah. Superficial vein draining the lateral aspect of the arm here. Cephalic vein. The basilic is the bigger on the inside, the cephalic is on the outside. These are the two that are different because we don't have those arterially. So look out for those today when we label the stick man or the stick woman. Artery that supplies the upper GI. Superior mesenteric, yep. So the inferior will do what's called the distal colon. Superior mesenteric does the small intestines and some of the large, but the inferior does the distal, lower part of the large intestine. Blood in the left subclavian artery, where is it going to flow next? It'll become the axillary. So it's the same artery, it just changes names like a straight changes names as it goes down. We'll see a lot of this today. Major branch off the aorta to supply the head. Big common carotid. Yeah. Major branch off the descending aorta to supply the legs. Common iliac. And the vein that drains blood from the digestive organs into the liver. Hepatic portal vein. So that's unique circulation here. It's, the vein, excuse me, liver is going to receive all that drainage from the intestines rather than going straight to being paid, it goes to the liver first. That's the new port that we're going to see. And then the hepatic vein is what carries it from the liver to the venous cava. All right, so some new stuff here in this PowerPoint. Let me make sure the recording is going here.
Are those questions that you
Okay.
just went over? They're not in the PowerPoint, but I don't know if you ever choose the PowerPoint, but they're not in the one I printed out like a month ago. Are you gonna put it?
I updated it Tuesday.
Okay.
Yeah. Yeah. And I put some new arrows in today's PowerPoint, so I'll make another update before you print again. I'll put some new arrows for some of the slides we're going to see tonight. Mainly just to speed up your learning, because there's a lot of up and down with the blood pressure, whether some things increase or decrease blood pressure. So just to make it all easy, I just put the arrows in there, just so everyone has it in print to see what the answers are. I'd like for you to work on guessing that, but again, I'd also like for you to have the right answer, you know, so right in front of you. So what we're going to see overall, guys, is that there's going to be more situations in the body, more physiological reasoning in the body to increase blood pressure. And that maybe goes against what we're used to thinking, because we're always thinking, oh, there's so many people that have hypertension. There should be more mechanisms in the body to slow things down, right? Well, there are a few, but there are more that raise high blood pressure, or raise blood pressure, I should say. And the reasoning behind that is that we want to be careful with perfusion rates and blood flow. If we don't have the right amount of flow in a given time to an organ, that's when you get really bad problems. So the body is more interested in raising blood pressure, less interested in bringing it down. Even though high blood pressure is not good in the long run, if you had a choice, let me put it that way, between high blood pressure and low blood pressure, you would always want to choose high because at least that could be managed. Low blood pressure is harder to manage. Your organs will shut down. Okay, so you could say, I know that's a very argumentative statement, but you could say there's more gray area to deal with high blood pressure, less gray area to deal with low. Does that make sense that way? Okay. Because we don't want the organs to shut down. All right, so blood flow is the actual volume of blood flowing through a vessel, flowing through the vessel. The perfusion is more of a rate. It's in a given time for a certain mass that tissue. So think of perfusion as a rate. I hate that. Gee whiz. So at rest, the total blood flow is quite constant and is equal to the cardiac output. That's what it should be. Remember, cardiac output, is part of that whole stroke volume times heart rate calculation. Okay. So for these, I'm not going to get too crazy on these, but just know the definitions as they're listed. This is a volume, right? This is a rate, the perfusion rate, the flow per given volume in a certain time. So when you think of this definition, you're going to have to see that word time in there. That's the key word that you want to look for perfusion, because it's a rate per minute. All right. Blood pressure, of course, is the force exerted on the wall of the vessel. So some of these slides are going to be real wordy. I'm just going to try to condense what we should be looking at. So the top number, the systolic, is that first hit on the internal arterial wall. And the diastolic pressure means as the pressure is released, which represents between the beats. So when we take the 120 over 80 BP, the 120 is the highest amount of pressure on the internal vessel, and the 80 represents when that pressure lightens up between the beats.
You said the systolic is releasing, the systolic is increasing, right?
The systolic is the most force put on the vessel, and the diastolic is when that pressure is released between the beats. Yeah. The pulse pressure would just be the difference between systolic and diastolic. So it's basically just some simple math. I'm not going to be hung up on this mean arterial pressure. You will not have to do this calculation. So other than just being known as a better indicator of perfusion to the organs, that's all you should know about the mean arterial pressure. Which measurement is the best to indicate perfusion to the organs? It's the mean arterial pressure, but you're never going to have to calculate this. So just underline this statement here, indicator of perfusion to organs. These definitions are really picky, so,
We don't know. Of course,
you don't have this slide?
no.
Well, that is weird. Maybe it's in a different place.
It's in the new PowerPoint. We have the old one.
Oh. Mhm. I do, especially in AMP2, they change a lot because I get more inspired. If you want to call it that. Okay, so resistance, we did hear about this one before. This is opposition to the flow. So anytime there's more resistance, your flow is going to be decreased, pressure increases. That's why the smaller vessels, the arterioles, as we get smaller and smaller and smaller, the pressure increases, right? And the flow decreases. And that's kind of the whole point. think I'm missing some. Every time I pause, it checks out on me. Oh, that's so irritating. There we go. Increased resistance means decrease in flow. So as you get smaller in the arteriole, increased resistance which will decrease the flow. This is also known as peripheral resistance. So the peripheral meaning furthest away from the heart. It's caused by the diameter, of course. So blood viscosity would also be a factor. This would increase the thickness, you could say, which would also increase the resistance, which would decrease flow. So from this point on, this lecture tonight is going to be a lot of putting these things together. Whatever increases or decreases the flow, increases or decreases the blood pressure. So that's a lot of what we're going to see tonight. The management of the vessel system, really. Also, the longer the vessel, the greater the resistance. So larger individuals will have more blood vessels, therefore encounter more peripheral resistance. So blood viscosity is a given. Total vessel length, the longer, the more resistance, the least flow, right? The slower the flow. And diameter, of course. The smaller diameter, the increase in resistance, which would also decrease the flow. So large arteries, of course, contribute little to peripheral resistance. The small ones are going to be the major determinant. That's just like a summary. Are you catching on so far? We're about to get into some other chemical things that will increase or decrease the BP and stuff like that. That part's kind of interesting. So there we go. I've got a lot of review or summary slides in this. So again, if resistance increases, blood pressure will also increase. And when blood pressure and resistance increase, this decreases the flow. I know we did some of this last time, right? We at least introduced that idea, right? So small diameter, right? Long vessel, viscosity, right? All these things will increase resistance, increase pressure, but slow down the flow. Okay, I'm not going to worry about this one here. Let's skip that. BP does tend to rise with age, of course. A lot of that is the compliance of the vessels. With arteriosclerosis versus athero, arterio is the stiffening of the arteries due to deterioration of elastic tissue. So like in all aging, it seems that tissues and connective tissues especially and muscles seem to degenerate. So this is what this is basically a weakening in the form of a stiffening of the elastic tissue. Compliance means the ability to kind of withhold and keep up with the pressure going on. So without compliance, you lose elasticity. That's actually what losing compliance would be, is losing the elasticity. So the elastic nature of tissue is to be able to return to its original shape. So if an older person rises up from a seated position for too long, they may get dizzy, right? Because we don't have proper compliance in the vessels to beef up the blood pressure. When you stand up, you get a momentary drop of blood pressure, right? And that points to the loss of elasticity in the vessels. Athero is the plaquing that can build up. Lipid deposits that can become calcified, right? The danger with lipid deposits being calcified is that when platelets, are breezing through the bloodstream, platelets are extremely sensitive to anything that's not smooth, right? So the more the lipids, build up on the inside of the wall, they attract calcium. And then when it hits those calcium deposits, possibly, that's what can trigger these small, tiny clots that then build up on top of the lipid, which become plaqued, you know. And that's when one of those little blood clots can break free, you know, and become dangerous. So the blending of this, not a good situation. Hypertension, of course, high blood pressure. You know, sometimes people have, you know, hereditarily, hey, did you need something? I'm sorry. Oh, you're fine. That's okay. We got it. We got it. You know, regular blood pressure can be 120/80, but some people trend lower. And then usually it's not a concern for doctors if that's their trend. But if you have fluctuations of your blood pressure from 1 week to the next or 1 month to the next, that's a different story. Some people may trend higher, some people may trend lower. But a chronic resting BP with above 140 or 90, you know, would be a high blood pressure. Older people do have a higher BP for sure. Yeah.
For men and women, is it the same?
Yeah, it's roughly the same. Yeah. Men can typically have more high blood pressure because they have more vessel length, that kind of thing, more resistance. Yeah. Hypo is, of course, low. All right, so blood pressure determined by cardiac output. What are those two factors? Anybody remember? Stroke volume and heart rate, right? So if cardiac output goes up, what happens to BP? What's that? Yeah. That is right. Blood volume, of course, regulated mainly by the fluid volume. So the amount of blood is written. If blood volume goes up, blood pressure goes up. That is why you don't want too much solute, of course, in your blood, like salt, because it'll attract more water from your body tissues, raising blood volume, which will raise the BP.
Regulated volume.
By volume, yeah. Solute concentration in the blood regulates the volume, so you can put solute concentration here. Plasma proteins, that kind of thing.
What were the two factors?
Stroke volume and heart rate.
The blood volume wouldn't be regulated by the kidney.
It's regulated by the kidneys, yeah, but it's that's what regulates the solute concentration, yeah. And kidneys regulate solute in the blood. All right, so here we go. A patient with polycythemia, right? Too many red blood cells. Would this increase or decrease viscosity? It should increase viscosity, right? Increase or decrease resistance? Increase resistance. And what about blood pressure? Increase again. Patient's body is depositing fatty plaques. Will this increase or decrease resistance? Increase. What about blood pressure? Increase. Good, good, good. You've gained 20 pounds. Everybody during COVID, right? Oh my goodness. So for every 2.2 pounds, you produce 400 miles, Jesus, of blood vessels. Obviously, you've increased your blood vessel length. With this, right, with this increase or decrease resistance. What did I say? Did I say something wrong? Yeah, it's true. Yeah. And we also increase pressure, of course. So you see the trend, increasing resistance would increase pressure. Right, which is why when you take the flip side of that, for diabetics that do go on the right kind of diet and they lose weight, they condense the blood vessels and things like that because you lose a bunch of fat, so the blood vessels just shrink up, that lot of collateral circulation, which lowers everything. So think of all these extra pounds as, extra load on the heart. That's what it really comes back to. The afterload, pushing back on the left ventricle, of course, and the venous return responsibility of all those vessels coming back. That's the extra load put on the heart there.
You lose the weight and they go away.
Yeah. Yeah. So it's like having more kids to feed. Good God. We all know how kids eat. All right. So more questions. Patient diagnosed as having a post-pituitary tumor. What causes that causes hypersecretion of ADH. ADH is one of the good things we're going to learn. Anti-diuretic hormone. Anti-diuretic hormone means it stops your body from losing water. So this is water retention. It's because we all know a diuretic, you lose water, right? So anti-diuretic is our body's natural ability to say, hey, kidney, we don't want to be letting go of all that water. Let's reabsorb it before it gets lost in the urine. That's what anti-diuretic hormone will do. So will this cause water loss or water retention? A hypersecretion of ADH would be a whole lot of water retention, yeah. Will this increase or decrease blood volume? Of course, it will increase blood volume, which will increase what? Blood pressure. There we go. So in this case, this is not what we want. This is an increase in blood pressure in the wrong way from that hypersecretion of ADH. ADH is also known as vasopressin, causes vasoconstriction. So now we're talking about the lumen diameter getting smaller. Would it increase or decrease resistance? Increase, very good. And what will flow? Decrease, there you go. And how about blood pressure? Increase, perfect. And hyposecretion would, hyposecretion would be the obvious difference. You'd have too much water loss and hyposecretion. So that hyposecretion is sometimes called, diabetes insipidus, where you're peeing a lot because of all the fluid loss, but you're peeing way too much. So it seems like sugar diabetes, but it's diabetes of a different kind. Insipidus, caused by another problem with the hypothalamus or the pituitary. So in the old days, if you were one of those lucky few that could test the urine of a diabetes patient, you'd either test it, you taste it. If it's sweet, you had sugar diabetes. If the urine was not sweet, you had a more serious problem going wrong with the pituitary or so. So wouldn't you love that test? All right. So blood flow through the vessels along the pressure gradient. Yes, yes, yes. That's all nice and good. So we start off high pressure, right? And as we get through the network, you can see the pressure. It would decrease when you get down to the vein level. Remember, veins have low blood pressure. That's all that means to say, as it's measured on the arterial wall. So I don't mean to make a big deal of that. I'm not testing you on these values. That's why I'm skipping through them, okay? I'm trying to skip where I can, which means you can just cross it out. I'm not going to ask you about that. Yeah, we can skip that too. Okay. My goodness, this PowerPoint's huge, so we got to skip where we can. Because the bigger part of today is understanding the whole thing you've already done, the resistance, the flow, all that kind of stuff. You're getting that. So that's when I ride that wave. And because we got to get to these blood vessels and make sure you know the stick models. The next big stage we're going to get into is seeing some of the mechanisms hormonally, how blood pressure can be increased or decreased. So that's some good stuff too. Which will ride us right into our next unit of endocrine system. It'll be a good prequel of that. So the main factors with blood pressure, of course, cardiac output, peripheral resistance, as we saw, and overall blood volume. Cardiac output, of course, they increase, resistance increases, blood volume increases. All will increase blood pressure. Oops. Short-term controls, nervous system, the vasomotor center, coming in the medulla oblongata, and baroreceptors. These are short-term controls. The peripheral resistance is mainly controlled locally in the vessels as it needs to. So these are other just controls that are mentioned. Chemoreceptors can also detect rising CO2 levels. So that's the big idea in these chemoreceptors we have, like in the carotids, and there's some in the aorta too. They're sensitive to O2, but they're more sensitive to CO2. That will immediately communicate with the medulla to set the rate for respiration. So high CO2 levels, especially here, reaching the head and neck, are going to be measured right there at what's called the carotid body. That's going to be one of those chemoreceptors embedded in the vessel to detect high CO2. Which means, we'll talk about this in the respiratory chapter, high CO2 means acidic levels of blood. So if you want to see this trend right off, high CO2, high hydrogen ion means acidic blood. So they all three mean acidity. Respiratory acidosis, which the body is naturally going to have a compensation for that. So how do we compensate for respiratory acidosis? Just if we want to play the game for a bit. Take a deeper breath, right? To get more oxygen in. That's right. That's right. And then the kidney will step in and manage compensation metabolically by getting rid of hydrogen ions through the kidney, which will help, regulate that pH. So it's a big game that we're going to talk about in the respiratory chapter that we don't need to get into right now. But this is a very sensitive detection here of a chemoreceptor for CO2. And there's also, it's not mentioned here, but there's also stretch receptors in the lungs. So your lungs can detect if you're not really moving your lungs in and out a lot, that are not being stretched. It's a big problem with the elderly because a lot of times they don't breathe deep breaths at all. They really don't, especially if you're living your retirement years in a lazy boy. And oh my God, I have a huge bone to pick with lazy boy. The way they make chairs is just horrible because you literally, it's a concavity in the back of the seat, nothing to hold you upright. Good Lord Almighty, it's terrible. Completely collapses your rib cage. You can't breathe like that. You have a talk with me. So take your time, look at some of these things. This is that receptor here. It's the blood pressure receptor in the carotid sinus. So it detects the pressure against the arterial wall right there. And that's how we regulate the lumen diameter. So just take your time, maybe come through this and see how it affects the overall story. So first of all, it's regulated. This is a lot to take in for tonight. That's what I'm saying, come back to it. So high blood pressure is our stimulus, right? The arterial blood pressure rises above normal, of course. It's sensed here in the baroreceptor. Sent where? To the vasomotor center. Then we have a sympathetic impulse causing a decrease in heart rate. And decreased crunch, what was that? A decrease in sympathetic impulses. I'm so sorry about that. This is the mechanism to fix it. So we decrease sympathetic output from the body, which would decrease the heart rate and contractility. And then the vasomotor impulses allow vasodilation. So that's one way we can cause a decrease in resistance. We've been talking about an increase in resistance all this time. This is the way the vasomotor center can control blood vessels by opening them up to decrease resistance, to help increase flow. So by relaxing the arteries, we decrease the resistance. That's what all this is trying to do. So we're basically telling the sympathetics to calm down, which doesn't always work. All right, so the flip here, a decreased blood pressure will also be sensed. We send that to the brain. Now we want to increase sympathetic impulses to the heart to increase heart rate and contractility, which would naturally cause a vasoconstriction. So this is the story that we're mostly going to see, right? The body's going to run this cycle on this side a whole lot more than the other side. It's naturally concerned about keeping pressure in the system. All right, cool. So here's the game. Adrenal hormones will increase BP. This is epinephrine, this kind of thing. Adrenaline, right? Antidiuretic, since it more water reabsorption, more fluid volume will increase BP. Alcohol actually inhibits ADH, causing you to pee more, right? Decreasing BP, at least temporarily. Angiotensin 2, this is one of these cool things we see. This is the kidney releasing a hormone called renin. So if we have low blood pressure, the kidney is going to want to release renin, which will start off this cycle of angiotensin 1 being converted to angiotensin 2. Angiotensin 2 is the powerhouse. This is the vasoconstrictor right here. Angiotensin 2. That's the natural vasoconstrictor to raise blood pressure. Atrionatriuretic peptide, ANP. This is a hormone coming actually out of the atrial cells of the heart, oddly enough. This is one of the weaker feedback loops we get, but it is one that decreases blood pressure. And then histamine tends to be a vasodilator. So it is a decreasing in blood pressure as well. That's why antihistamines have to be taken carefully with heart patients, because you don't want to increase the blood pressure too much more with an overdose of antihistamine. Okay, so I'll tell you, it's a lot of arrows, isn't it? These may take a while to digest. Most of them are pretty, straightforward, but maybe a couple of them surprised you. This angiotensin cycle is going to be a big one. That's a big cascade going on with that. And the major players that we're going to hear most about are going to be ADH and angiotensin. So just know those two for sure will raise blood pressure. Okay. So one of the first things they do for a patient with high blood pressure is want to control that ADH. So they give the person a diuretic to get them out of the danger zone. That's the fastest way to drop someone's blood pressure is a diuretic. And then if you've ever heard of ACE inhibitors, ever heard of those? ACE means angiotensin converting enzyme. That's what converts angiotensin 1, which is the inactive, to the angiotensin 2. So if you catch it in the bud, if you catch that converting enzyme in the lungs, is where it is, and stop it from converting to angiotensin 2, then you can stop this over vasoconstriction and calm down someone's heart rate or blood pressure like that too. But with all these medications, there's always some kind of funny side effect, you know. With the diuretics, then the person could become dehydrated if they do too much of it or for too long, right? Or their magnesium levels drop so much, then their legs are weak. Then they're weak, they're gonna fall. Then they break their hip, you know. It's a terrible story sometimes. So everything's got to be monitored. with ACE inhibitors, since it's a thing in the lung, it causes these patients to have a chronic cough, even though they're not sick. So all kinds of funny things come around. All right, so blood velocity decreases for 3 reasons from the aorta to the capillaries. The greater the distance, the more friction, of course, the more resistance will reduce the speed. Smaller radius, like we said again, offers more resistance, which also decreases the flow and speed. Doesn't it sound like we say the same things over and over again? That's kind of how it is. And of course, the distance, like we said, farther from the heart, the number of vessels and their total cross-sectional area becomes greater and greater. So when you get down to the other anastomo, not the anastomoses, but the vessel networks and stuff like that, when they all come together, the cross-sectional area, you get more resistance the further from the heart. The smaller the vessels and more resistance. This is a very sticky part of the PowerPoint because it's so kind of repetitive. So from the capillaries coming back up to the vena cava, the velocity will start to increase again. Veins are larger, which means less resistance. That statement right there says it all. Let's focus on that. In the venous system, there's going to be less resistance because the lumens, are bigger. But we never regain the velocity that we had in the large arteries at the start. It's a low pressure system. But overall, veins are more compliant because they're built. They have a little more connective tissue. They're built for stretching more. And plus, they have the benefit of valves, don't they? Right. All right, 3 ways of controlling vasomotor. When you say vasomotor, we're talking about the muscle, the muscle activity in the veins, or excuse me, in the arteries. Local, neural, and hormonal. So autoregulation, this accumulation of waste, it stimulates blood flow, which is increasing perfusion. So this is blood flow here. I thought I had a little thing right there, but it did not come through. Sorry about that. Oh, I think I know what happened. 1 second here. Let me break this for a second. Oh, there it goes. Okay. There's my blood flow. So chemically, we can, by the platelets and endothelial cells, these are sensitive cells, of course, that can regulate histamine. Things like histamine, bradykinin, and nitric oxide can stimulate vasodilation. So these are sometimes secreted by these endothelial cells. Angiogenesis, the growth of new blood vessels. So that's only really done when there's a need. This could happen, of course, when you gain weight, or if you're overly physically active, building up endurance and that kind of thing, you build new blood vessels as well.
Angiogenesis is
growth of new vessels. Growth of new vessels.
And also it happens when you gain weight and what?
Or exercise. It's also seen in the heart. If the heart's being overstressed, it can build new vessels. We kind of already talked about that. New coronary vessel growth helps temporarily to feed the heart more O2, but then again, it starts to increase more resistance in the coronary vessels and becomes a problem after that. So widespread control over the blood vessels throughout the body is good for the vasomotor. So why do coronary vessels dilate?
You don't want.
Yeah, we want to increase flow, right, to coronary vessels. Yep. So some of these other neural controls here, the baroreflex, this is our short-term regulator. This is kind of what we just saw in the other thing, the other slide before. It's more of a review actually on this point. Remember that whole feedback cycle we just looked at? This is the same thing. Increase in BP detected by the carotid sinus right here, the one we just saw the picture of with the seesaw cycle. This is just a rehash of that. Results in an inhibition of sympathetic impulses and an excitation of vagal parasympathetic. So this is kind of a repeat slide, to tell you the truth. So chronic hypertension, shoot, that's a tough one. Why doesn't this work in chronic hypertension? Basically, it's what's called a habituation of the pathway. So it basically kind of just doesn't pay attention as it should. Right here, if low BP is recognized, or excuse me, if high BP is recognized, it inhibits the sympathetic and excites the parasympathetic. All right. So these chemoreflexes, very sensitive to CO2 levels, like we said. Hypoxemia is low O2. Hypercapnia, high CO2. That's basically saying the same end result, which will result in acidosis, stimulating vasoconstriction. This will increase blood pressure, of course, increase lung perfusion, which is that rate, and gas exchange. So we're basically pushing more blood into the lungs when we say this, which is how you fix high CO2 levels, because in the lung is when the red blood cell unloads, gets rid of the CO2, and loads up the O2. So if you can catch the regular trend, guys, of just noticing that things will always need to regulate themselves best they can, either through lumen diameter or through pH like this, with this acidosis story. I mean, if you back away from everything, all the words in the slide, because it gets to be a little monotonous, it really does. If you back away and you think, okay, if I'm low O2 and high CO2, what do I need to do? I need to breathe more, right? So we need to increase O2. So we want to increase circulation and rate to the lungs to get that O2 and to get rid of the CO2. An ischemic reflex, if you know what ischemia is, then you know what needs to be fixed. Ischemia is a natural lack of flow, a drop in perfusion. So this is where we stimulate what? Sympathetic signals to heart and blood vessels. If we increase the heart, we're going to increase flow to get oxygenation in the lungs. So any questions that come about like this, it's really just saying the same story in a different language. Instead of saying low O2 or hypoxia or high CO2, which is hypercapnia, hypoxemia and hypercapnia and ischemia, Jesus, we're all saying the same thing. You know, ischemia is a lack of flow, which means low O2, right? So we're just using a different word to really indicate the same thing. We want to increase the sympathetics to increase heart rate. And you can even go so far to say as decrease parasympathetics, right? So we want to raise BP and restore normal perfusion to the brain. in the case of an ischemic reflex. All right, so here we go. Angiotensin 2, a potent vasoconstrictor. Will it increase or decrease BP? It should increase, yes. Atrionatritic peptide again increases urinary sodium excretion. What do you think happens with sodium excretion in the through the kidney? Sodium leaves the body. What follows solute? Water. So it's kind of like a diuretic, right? So this would decrease. ADH, which promotes water retention, increase. Epinephrine, which is a sympathetic stimulus, right? That will be an increase as well. All right. So these are more review slides here. Long-term controls again, regulating blood volume with increased BP, stimulating the kidneys to eliminate water, thus reducing BP. Another long-term control for decreased blood pressure, it stimulates the kidney to increase blood volume, which means retaining. So which hormone would be doing this here? Which would increase blood volume by water retention? ADH, right. Beautiful. And this would be your ANP that we just saw, the atrionatritic peptide. So ANP right here, ADH right there. So when blood pressure or blood volume increases, filtration rate increases, more urine produced. And the indirect renal mechanism would involve that renin-angiotensin system, which we're about to see in the next slide. Here we go. So if blood pressure declines, the kidneys will release renin. This is coming out of the kidney. And through the conversion, we're going to get angiotensin 2, which is our vasoconstrictor, which will stimulate then ADH and aldosterone. Aldosterone comes from the adrenal, ADH from that pituitary, but they're both going to do the same thing in the case of water retention. So in this case, blood volume will increase, which will increase the blood pressure. Both of them. Only difference in this one is that we have a secretion of potassium. We'll see that in a later chapter, though. But focus on these two being the main drivers. Of course, started from the renin cycle here from the kidney, but these are the main drivers that keep BP on the up. ADH and aldosterone. Both reabsorb water. All right, so we've already talked about that. We can skip over that. Let's do some more questions. So I moved these questions. You might have seen these earlier in the PowerPoint. I just brought them to this stage. So you might have to flip a few pages if you're following along. Beta blockers, which are receptors for sympathetics. If beta blockers, a beta is the receptor, a beta blocker would be blocking the receptor for a sympathetic impulse. So if we block receptors for sympathetic impulse of epinephrine, what happens? Increase or decrease? We should get a decrease of blood pressure by blocking sympathetics. So again, if I misspoke, the beta receptor is the receptor for sympathetics, right, on the heart. If we block that receptor, it helps us reduce blood pressure. Nicotine will also cause vasoconstriction. Will this increase or decrease? Of course, this will increase. Diuretics increase urine output. Will this increase or decrease blood pressure? It should decrease it. Is your head spinning yet? Jesus, I know. Angiotensin converting enzyme inhibitors. So if you know what ACE is, then you know what angiotensin does, right? It's going to make that BP come up. But this is an inhibitor. So what should we expect? A decrease. That's a lot of words, isn't it? In the number 4. But that's why ACE inhibitors and beta blockers and diuretics, Jesus, they're all here, right? All the major treatments to go against high blood pressure there, except for nicotine. We don't want too much of that. All right. So you can see what a smoker might go through if they're on these medications. They may not work like they should. Of course, the nicotine will be competing with all that. All right, how about hypothyroidism affecting heart rate? Right, so this is another hormone enabled pathway, right? Thyroid is metabolic rate, which would naturally increase. So hypothyroidism is a decreased thyroid metabolic output. So this should do what? Decrease the cardiac output, right? Ventricular hypertrophy due to exercise. This should increase heart rate, cardiac output. Ventricular hypertrophy due to congestive heart failure. This would eventually decrease cardiac output. It would increase it slightly at first, but not overall. Eventually, it would decrease it. Nicotine, this would increase cardiac output because it's a stimulant. All right, so a patient has pericarditis, large amount of fluid pressing on the heart. This is preventing the heart from preloading. We want that nice, crisp preload stretch on the heart. What will this do to stroke volume without a good preload? This will decrease the stroke. Remember, stroke volume is the amount of blood coming out. So that's going to decrease it, which would decrease the cardiac output. ESV, if you remember that, that's the end systolic volume. So what's the goal of the ventricle? To get all the blood out with a nice crisp contraction, right? If you have a weak cardiac output, which is what we got here, will we be able to pump every drop of blood out of that ventricle? We won't, right? So will this increase or decrease end systolic volume? It will increase it because it means you'll have blood left over. So when there's the volume of blood still in the ventricles, that's called end systolic volume. We want ESV to be low, meaning that there should be no blood left in the ventricle. That's what we're trying to say. No blood left over. But with the low cardiac output, we do have blood left over in the ventricle. That means the heart's not able to squeeze everything out. Okay. So that's what happens with pericarditis, the fluid around the heart. Okay. So some of this, I think, is what we've already said. Yeah, we've already said these. These are, again, more review slides from what we've already done. So decrease in tissue oxygen, increase in acidity, which is hydrogen ion based or CO2 based, all this stuff will increase acidity. So we vasodilate when we have these situations. Vasoconstrict is due to sympathetic stimulation. So with these kind of questions, we just want to ask what would happen with increased sympathetic stimulation. You get vasoconstriction. With vasodilation, this would happen when there's a decrease in tissue O2 to try to bring more flow. All right, we can skip that. These are all actually review slides. This picture just to show the amount of blood during exercise given to the muscles. Of course, I think it's kind of ridiculous to have this question or this picture. It's going to be more increased to skeletal muscle with exercise. So we can skip through that. All right, this is the last part of the PowerPoint, guys. Exchanging capillaries. And then we'll break before we do lab. I know this has been intense. I'm so sorry. If you can come away from the last hour just understanding what increases rate, resistance, flow, blood pressure, those kind of things, maybe go through those questions again. If you're not getting every single slide in the PowerPoint, I understand it's a lot for one night, but if you can answer those questions we did with all the up and down arrows, you should be good. Okay, because that's what's going to be coming at you. So just practice those questions. That's why we're in here doing them. All right, so most important method is diffusion. So plasma solutes can come through nicely because they're solutes, but large plasma proteins don't diffuse. They're too big. So otherwise, diffusion, of course, lipid soluble and gases go right through. Anybody remember what that's called? Is that simple or facilitated? Simple diffusion, right? Of those non-polar gases, at least. Water soluble diffusion, that will be our facilitated. Transcytosis, large water soluble molecules and certain antibodies. Remember we talked about NAP1. We bring something in the cell using endo. We transport it across the cell, which is trans. And then we push it out of the cell with exo. So this is really an NAP1 slide for you too. So diffusion, yes, we can expect that. That's what capillaries do, guys. Capillaries are there to exchange nutrients and wastes back and forwards by using the two methods of diffusion we talked about. Transcytosis, endo and exo, used for larger molecules that can't fit through these diffusion channels or through the cell membrane so easily. They're too big, right? That's just showing you what the capillary will look like. We've already talked about the three types, right? Bulk flow, most important in determining relative fluid volume. So capillary hydrostatic pressure produced by, let me read that again, direction. Yeah, the capillary hydrostatic pressure is produced by the blood pressure. The colloid osmotic is produced by the solutes that are present. This is actually something we see in the kidney. So let me put it this way. The hydrostatic is the pressure that's coming. The pressure of the fluid, the water in the blood, pressing through that capillary. That's what hydrostatic pressure is. So if things are trying to diffuse outwards and inwards, it's met with that pressure that's already in that blood vessel. That's what helps that hydrostatic pressure move things through. So it's basically the pressure of the blood, the water in the blood. The colloid osmotic pressure is the pressure created by solute, which attracts water. What's that?
Would those be like plasma proteins?
Those are the ones that create the most osmotic pressure. Yeah, the plasma proteins, right? So all the plasma proteins like albumin in the blood, that is the largest constituent, what makes osmotic pressure, yeah. So when I say solute concentration, the bulk of that is going to be these large proteins. Remember that case study we talked about in AP1 with, forget her name, Trish. I think she was starving herself and she lost a lot of the plasma proteins. You remember that at all? Oh, yeah. Starvation, when you start breaking down proteins and stuff, you lose your plasma proteins. Yeah. that creates a difference where you start losing a bunch of water out of the blood vessels. So that's what you need. Osmotic pressure. Let me put it this way, because I know I'm probably losing gas. You need solutes, including plasma proteins, to stay in the bloodstream to always attract water, like in a good way. Without those, you don't have water in your blood, or don't have enough. So what happens when you don't have enough water in your blood? Your blood pressure plummets, right? So the best way to make sure your blood pressure is on the up and up as it needs to be is having those plasma proteins. That is why if you're a kidney patient and you got a damaged kidney, if you're losing protein through your kidney, that's extremely dangerous because you could die really fast. So go back to the first statement I said at the beginning of the lecture. Which one's better, high or low blood pressure? With high blood pressure, you can die slowly for 20 years, if you want to put it that way. With low blood pressure, you die really quickly in a couple of days. So that's what I meant, when I said that. So that's why the body, through all these mechanisms, ADH, aldosterone, angiotensin, all this stuff, have more mechanisms to keep your blood pressure up, to at least keep you going. All right. You can skip that. All right, last few things here. Types of shock. Hypovolemic shock. That's a large scale blood loss. We were just talking about that. This is more so through bleeding, though. Internal bleeding or any kind of bleeding like that on a large scale you're losing the volume of blood. Vascular shock, poor circulation from overdilation. Cardiogenic shock, the heart cannot sustain adequate circulation. So weak heart. Whether it be right side or left side, you could, still back up the circulation. So think of vascular to mean blood vessel. That's why you get vasodilation. The poor problem there. Volume and volemic right there. Cardiogenic means it's inherent in the heart itself. That's vessels, right? That's what I'm trying to get you to see the word association. Vascular is vessels. Cardiogenic means intrinsic to the heart. Volemic means volume of blood. It's easy to lose sight of what these three mean, but if you pay attention to those little words, that could help. Venous pooling with inactivity, like right now. You guys are sitting all this time. Anyway, with venous pooling, the weakness, you could say, that occurs without now this happens really when the person has been sedentary for a long time, not just an evening or a week on a cruise, but years and years and years of too low of venous pressure would cause this venous pooling. So with prolonged standing means without moving. They should have said without any movement. It's not just prolonged standing, but the fact that you're not moving, right, is the bigger deal. Cardiac output may be low enough to cause dizziness. So waiting in line for Mine Train in Disney World when you're 75 is probably not a good idea. Or even worse, Rise of the Resistance. Have y'all ridden that? The Star Wars ride? Any Star Wars fans? Yeah. Oh my goodness. I've got to ride that. It puts you right in a movie on that ride. It's crazy. Crazy. Or the Avatar ride, Flight of Passage. Have y'all done that one? That's unreal. You got to experience that in your lifetime. It's pretty crazy. Long line there too. Shoot, Splash Mountain just closed a few weeks ago or 2 weeks ago. They're redoing it as Tiana's Bayou Adventure. So anyway, I think the wait time was up to like 500 minutes on the last day of Splash Mountain running. But it's a cool ride. A lot of nostalgia with that ride, but it needs to be redone. So it'll be beautiful with Tiana. I'm glad they're doing it. It's all broken down and everything. They need to change it. And no one is even attached to the theming of it at all. It's just lost in today's world, really. So I mean, no big deal. It'll look better when they redo it. So yeah, this could be a large Venus problem. Jet pilots without pressure suits, when they hit those G's, good God Almighty, all the blood goes to your extremities when you're hitting those G's. So without the pressure suits to squeeze your legs and send that blood back to the heart, all your blood is in your feet. So which can make you pass out. So those pressure suits help keep jet pilots conscious. I got to sit in I think it's an F-14. Is that that's a plane, right? F-14, the fighter jet in the Gulf War. My brother-in-law was a fighter pilot in the Gulf War. So I got to sit in one of the planes. Never flew the darn thing, of course. He showed me the manuals on how to fly this thing. It's like 6 manuals, this thing. No, thank you. But yeah, man, there's no space in those planes for nothing. He would fly like 38 hours straight, refueling in the air. How do you stay awake for 38 hours? I don't know. Yeah, they're hooked up. I don't know about the number 2 part, but I don't think I want to know. Okay, we already saw these. Inadequate pumping of the heart for cardiogenic, low venous return. Output is too low. Yeah, these are just all review slides. Okay. If I skip over anything, it means I'm not going to hold you to it. So don't. I'm going to tailor it to what we've focused on. So this is anaphylaxis, this last one. All right, guys, we are done with that. Let's take a break and come back and do our lab stuff. At least looking at the blood vessels, you will be able to do it. All this stuff, you might need a drink to get through that again. Yeah. Okay. With patient 2, right? Damien, a 59-year-old. So he has a TIA, an ischemic attack, which is like a mini stroke, right? If Damien experienced numbness, number 6, on the right side of his body, what side of the brain would be controlled? Left side. So it'd be the left parietal for this motor control, left parietal lobe. So we're looking at the EKG now. Number 7, which wave of the ECG or EKG would show abnormality with atrial fib? What wave controls atria dipole? It'd be the P wave, right? So since this is a systemic problem, this is a confusing one. I would ask which side, which atrium? Since this is a systemic problem, right? Not going to the lungs, we're in the brain, right? So this is in the systemic circuit. So it'd have to be left atrium where that clot came from the weak atria, the AFib, a clot, because blood pools in that left atrium. In that case, when it's weak, and it causes a clot. So left atrium on that one. Number 9, this would go eventually, if the clot formed in the other atrium in the right, it would go to lung capillaries. So for number 9, where it's the opposite scenario, if it were on the right, it would go to the lung for number 9. And then be a pulmonary embolism for number 10, a PE.
Before you move forward, can I get you to go back, if you don't care?
Which one?
To page 45, number 4.
So I got left brachiocephalic and then.
Yeah, left brachiocephalic would take you to the superior vena cava, into the right atrium.
Yeah, but I missed the one, like I missed something.
From left brachial vein comes left axillary. From left axillary comes left subclavian. from left subclavian comes the brachiocephalic. Okay. Okay, so back to number 10, the pulmonary embolism for Trish. Oh, no, not for Trish, for Damien. My bad.
Did you say the superior vein cover or the inferior?
Superior? Yeah. All right, so labeling these on the next page, 48. 11 is your basilar. Which is going to be the blending of 15. 15 is your vertebral artery. So look how the vertebral artery comes up the cervical spine on both sides to blend to become the basilar. So 11 is basilar, 15 is vertebral artery. These are all arteries. 12 should be that internal carotid. 13 external carotid, which will go to the, the scalp and such. The internal carotids go up to the middle of the brain. Then 14 is the common carotid artery. Again, 15 is your vertebral. 16 would be subclavian artery. 17 is the good old trunk, brachiocephalic trunk.
What was the very top one? The very first one, the 10. Circle of Willis.
Yours is number
That's
10?
the name.
No, it shouldn't be number 10. It's just already named, Circle of Willis. That's the beginning of it right there. Yeah. So the anastomosis is just the joining of two blood vessels without a capillary bed. Like when the basilar artery is joined from the two vertebrals, that's an example of anastomosis. That and the Circle of Willis. So 19 is basilar and Circle of Willis. A merging of two arteries come together, Okay. So that was your next big old thing here. Are y'all good on this last page, 49?
Yeah.
What's that? LMO? Basilar. L should have been right vertebral artery. M is left brachial artery. O is the splenic vein. Right vertebral artery. Yep. Those vertebral arteries come off those subclavians, so that they're pretty small. So that is it, guys. All right. Test on Tuesday.
Oh, we don't.